Oh, hello there. We're going to talk about O2 devices. One of the things I want to mention to you before we get started is I'm setting up a lab next Thursday. And we're going to do what we did the last time we have a lab. We're going to have 8 to 9:30, 10 to 11:30, 1 to 2:30, and 3 to 4:30. And I put it in a announcement for you guys. What we're going to do is we're going to look at our equipment, take a look at it, see how it fits. How do you put it on? Since you've started pediatrics, we can also set up a hood, show you how to set one of those up, and then answer any questions that you have. So it should be kind of fun. What we're going to talk about then is we're going to talk about our devices. And one of the things you need to know is we have low flow and high flow devices, and there's a definite distinction between the two of them. A low flow device is one that does not provide all the gas the patient needs, and sometimes we'll say it does not meet the patient's inspiratory needs or demands. A high flow device is one that must meet and then exceed what the patient's inspiratory demands or needs are. And there's different formulas that go with these and different devices that go with them. You've been introduced to some of the high flow devices. You've seen the Venturis. You've also seen the large volume nebulizers, and we're going to talk a little bit about those and what they can do at that particular point. So basically, there it is. It supplies O2. The low flow devices supply O2 rich gas as part of the patient's inspiratory demands or flow. It's affected by four things, and these were at the end of the last PowerPoint, and that's your raft, your respiratory rate, your anatomical reservoir, and sometimes people will say anatomical dead space, tidal volume, and then the flow from the flow meter. If you stop and think about it, if somebody is taking a really tiny tidal volume, they're going to be sort of hoarding oxygen. And so when they breathe, they're going to get a little bit higher oxygen at that point compared to someone who's taking a great big tidal volume. At that point, they're entraining more outside air into their inspiratory needs. And as a result of that, they're diluting that oxygen, okay? The same with respiratory rate. If you're breathing really, really fast, you're entraining a lot of outside air into your flow of gas. If you're breathing very slow, you're starting to build up oxygen that you will take in when you take that breath, okay? About the only time that you can breathe really deep and fast is if you have Kussmaul's breathing. You remember Kussmaul's breathing is what we see with patients who have diabetic ketoacidosis, and it's very fast and very, very deep. Okay. Okay. So when we're trying to figure out what is the oxygen percentage we're delivering to a patient, one of the things we always have to remember, there's 100% oxygen coming out of the station outlet. What we're going to be diluting is that 100% oxygen. And basically what we do is we say for each 1 liter, we're adding 4% to room air. And when I show you the formula, look at that formula, sometimes you're going to hear people go, you're only giving the patient 8% oxygen. Well, no, we're giving them a flow of 28% oxygen. Well, I don't know where you got the other 20. People have a tendency of forgetting there's 21% oxygen in room air that has to be added to that 4%, okay, or 8%. Room air normally starts at 20.98%. Until this recent addition of EGANs that you have, we used to just use 20 plus whatever the 4 was. So if it was a 2 liters, it was 8%. 20 plus 4, 8 is 28%. So we'd say 2 liters, you're on 28%. What they've done in EGANs in the last 2 editions, and they have done it with the new one, is the same thing, is now they've flipped over to 21%. I can't tell you what the board's going to use, but I'm going to tell you it's really easy to figure it out. All you have to remember is add 21 to 4, which is 25, or add 20 to 4, which is 24. With our low flow devices, the FiO2 is variable. What do we mean by that? Basically, what we mean is depending on your respiratory rate, anatomical reservoir, the flow set on your flow meter, and your tidal volume, that FiO2 is going to vary. We're either going to dilute it or we're going to allow it to build up a little bit higher than we really want sometimes. But whatever it is, it's not going to be something that's fixed. We do not know sometimes from breath to breath to breath how much oxygen you're actually getting. So the formula for this, and this is their 21%, is what you do is you have your 1 liter on the flow meter. Remember, every liter on the flow meter is 4%. So 21 plus 4 equals 25%. That's the approximate FiO2 a patient's getting when they're on 1 liter of oxygen. Okay? If you see 24%, it's correct also, because like I said, until the recent additions of vegans, we've been using 20. What happens, as I mentioned before, people forget that that 20 has to be added to whatever we're delivering, because there's 20 or 21% of oxygen in the atmosphere. So there you see, at 2 liters, you're going to have a 4 plus 4, 1 liter 4, 2 liters, you've got that second 4, so that's 8%, plus 20 gives your patient 28% or 29% at that particular point. And the oxygen that we're giving them is approximate. So we have a formula that tells us where to set the flow meter. And we knew that because sometimes we're going, we think your patient's getting 32% oxygen. Where's the flow meter set? That'll tell me at this particular point. So the formula we use is your FiO2. What do we think the patient's getting at this particular point, minus that 20 or 21% that exists in the ambient air or the atmosphere divided by 4, because we know for every 1 liter on the flow meter, there's a 4% increase in oxygen. So here's your problem. Patients receiving 32% oxygen. Where do we set the flow meter? Well, 32 minus 20 in this case is 12. 12 divided by 4 is 3. That's exactly where the flow meter will be set. If you use 21%, it's going to be 32 minus 21, which is 11, divided by 4, which is about 2.7 liters per minute. We're not going to set it at 2.7. We'll set it at 3. And as we said, this is all approximate FiO2, okay? And basically, when we're setting the flow meter up and we're setting our patient up, when we set them and give them their flow, how do I know I'm giving them enough? How do I know I'm giving too much? I'm going to ask them, how do you feel? Do you feel like you're getting enough air? You need a little bit more. Okay, we can see if we can turn it up a little bit for you. Not terribly much, but we're going to make it comfortable for you. If it's too much and their eyes are flapping in the breeze and their hair is blowing up and hitting the wall, you definitely have to turn that down. Okay, so I'm going to bring this up here. So this is a nasal cannula. This is the most common thing you're going to see regardless of where you work. Home care, long-term care, acute care, LTACs, wherever they happen to be at this particular point. They give you low to moderate O2, okay? You can run them anywhere from 1/4 to 6 liters per minute. FiO2 range anywhere from 22 to 40%. Prior to this current edition, it used to be 44%, but because we've changed to 21%, now it's 40%. What happens with these is that when you run into some of your patients, you're going to see that they've put their napkin or box of Kleenexes or something over their ears. And the reason is that these will start to pull down on their ears, and sometimes it'll break the skin and they'll have a wound up there. When you come into the lab next Thursday, I'll show you what you can put on there to prevent that from happening, or at least help the patient while they're wearing these, okay? They also start to get dry at about 3 liters or 4 liters. When we talk about humidity, the American Thoracic Society, the ARC all say you don't have to add humidity to hit 4 liters. However, these guys don't live in Arizona, and sometimes in Arizona we need the humidity at 2 liters, if not a little bit below that. So the question comes up, well, how do you know the patient's dry? Is it just a good guess on my part? Well, when you go to see the patient, you ask him, "Hey, Mr. Jones, how are you doing there, sir?" And he goes, "I am so stuffed up, I can't breathe, and I can't eat. I don't know what you guys are doing to me." They're dry. And what they need is they're going to need some humidity. And there's no order. You don't need an order. There is no order that has to be written to give your patient humidity, okay? So just be aware of that. Um, in order to use this appropriately, you got to breathe through your nose. So if your nose is all stuffed up, we got a problem. You'll see this on occasions. We'll have our patients who are somewhat out of it a little bit, and they're breathing through their mouth, and we'll just take the cannula. You can clean it off with alcohol and then just put it in their mouth, and it works. Okay. This is a transtracheal catheter. We see this in home care. This is more home care than anything else. And if you look at this, you can see that this lady's got a little chain around it. It's got one of those little beaded chains. That's how you know it's a transtracheal catheter. It is surgically inserted at the second cartilaginous ring. Because we're bypassing the anatomic reservoir, we can use lower FiO2s to give us the oxygen for these patients. And the oxygen has to be continuous. The device has to be kept clean. Once the patient has had this inserted, they're taught how to clean it. So when they go home, they know how to take it out. And they do, guys, they take it out, clean it, and then they'll put it back in themselves. And what you hear people talking about is that they have a mature track, and the track is where the device goes in and comes out of it. You can see flows again a quarter to about 4 liters, 22 to 35%. People that wear this do like it because it's sort of comfortable and not glaring at everybody. Look, I wear oxygen, I wear oxygen. So some people like it much, much better. Problem you have, risk of infection, especially if you don't keep it clean. Another problem, easily to pull out. You got to be careful with that. And then there's this thing called mucus balls. The literature calls them mucus balls also. What they are is mucus plugs. So if your patient is getting dry, their secretions are beginning to dry and they're going to form these little mucus balls. And it will go ahead and block up the end of the transtracheal catheter. And that's one reason why you need to be able to keep it clean, okay? You probably have seen in the drugstores that they have those like little aerosol cans that have normal saline in it, and people will use those. They'll just put it on their transtracheal catheter and go ahead and squirt some of the normal saline in there and try to push those mucus plugs or mucus balls away. These are really cool devices. They're called the reservoir cannula or the oxymizers. You're going to hear people talk about those in the hospital. These are conserving devices, and they're conserving devices. Well, let me grab my little pointer here. That's my pen. There's my pen. This area through here, and then this portion right here is where the oxygen is being conserved. What happens when a patient inhales, they take the oxygen out of here. And you can see it's way up here. This is called the pendant. And then when they exhale, then the oxygen comes and fills this back up. Okay, and you can see it holds about 20 mLs more of oxygen. So it's delivering anywhere from 1 to 2 liters per minute more than a nasal cannula does at any of the liter flows. So sometimes, we'll have these patients that are on 6 liters, but we're not holding them there. They don't want to wear a mask. If your hospital says you can change into an oxymizer, you want to go ahead and do that. And you can run it at 5 or 6 liters and still meet the needs of the patient because you are delivering more. Your book, when you look at it, talks about home care, 1/4 to 4 liters per minute, with a flow of with FiO2 of 22 to 35%. In the hospitals, we'll do anywhere from 1 to 15. Your FiO2 is anywhere from about 28 to 85%. They are drying, and people are going to tell you, you got to put a humidifier with them. No, you do not use a humidifier with these, because what happens is that you've got some of this small bore tubing, And as the humidity is coming out of the humidifier, it'll sometimes come down here, go down through the parts of the cannula and get into these areas. When they do, it's now occupying space, and so there's less oxygen being stored. The other one you see, and you'll see it especially with this one, is if you start getting a lot of water up there, you're going to stop that oxygen that you need. Plus, it's a perfect breeding ground for any of the microbes that the patient may have in their nasal passages. And this just shows you a little bit as to how they work, okay? And you can see what the lady is doing when she's breathing. So you'll see these in the hospitals. The reservoir devices are your mask, okay? And part of the reason we call them reservoir is they can actually hold a little bit more oxygen in these areas, okay? And you can see this is a simple mask. And when I talk about this, I tell the students all the time, it's simply a mask. That's all it is. And if you look at it, there it is. It's simply a mask. And it has the tubing that comes up to it, a little thing that goes into it that you hook into it. And it is a mask, and that is it. It has a different type of strap, okay? These straps are pretty good, except if you don't have any hair, or if you have sometimes a lot of hair, it'll start to slide down, and we'll start to see these masks coming down a little bit. There's a little metal piece over the top. You want to conform it to the nose, just squeeze it a little bit, but you have to keep these out of the patient's eyes, otherwise it's extremely annoying. Masks, for the most part, are really not tolerated well. They're hot. People feel like you're suffocating them. Lots of excuses as why the people don't like that. With a mask, you have to have a minimum flow to flush out the CO2. A normal board question you'll see is, what's the minimal flow for a simple mask? And the answer is it's 5 liters per minute. Do not be surprised if you're working in a facility and somebody's on one of these and someone comes up and tells you, oh, we just turned it down to about 2 liters. They were kind of uncomfortable. Ladies and gentlemen, that doesn't work. You need to go and turn it back up to the 5 liters, okay? And if they're really uncomfortable, if they can tolerate a nasal cannula or an oxidizer, that's really what you want to do. Get them one of those, okay? The other thing, and just to throw this in with the nasal cannula and the oxidizer, if you have a patient who's awake, someone alert, doing pretty well, and they want to eat, it's extremely hard to eat with these masks on, because what you have to do is really crush the food up and try to push it through all these little bitty holes. Unfortunately, it doesn't work really well. So what can I do? Let's just change them to a nasal cannula or the oxidizer, okay? Flows for these, 5 to 10 liters per minute. FiO2 is somewhere around 35 to 50%. And then you have two that come up that seem to cause most of the problems for folks. This is what's called a partial rebreather. If you look at this, this has got a mask. It's got an entranceway for the oxygen to go in. When you're breathing in, the oxygen's going to go up for you. When you exhale, it's going to come out the little openings. It has little openings just like the simple mask does on the sides here, and that's for part of your exhale gases. However, the first third of your exhale gas is going down into this bag. Okay, and that's why it's called a partial rebreather. You're going to partially rebreathe that dead space you just exhaled. Now, the bag is going to fill during exhalation, and what you need to make sure is that this bag stays at least 1/2 to 2/3 full at inspiration, okay? You want to see the bag go down a little bit, but you don't want to see it go down a tremendous amount, because then your patient's not getting the oxygen that they actually do need. What you're going to see too is you can also entrain some outside air through those little openings. Don't count on it for a long period of time, because your CO2 is going to start building up, just like with the simple mask. The flow in the book will tell you the minimum is 10 liters per minute, enough to keep the bag from collapsing. These have an FiO2 of 40 to 70%. So this is the non-rebreather. This is probably the second most common device you're going to see behind the nasal cannula. And when you look at these two, and it's really kind of a cool picture, this is the partial rebreather. And if you notice, there's nothing here. This is open. That's why that first third of the exhale gas can go into the bag. With the non-rebreather, there's a one-way valve, okay? And that one-way valve opens, not tremendously. You should see it fluttering a little bit. And when the patient's inhaling, and that's allowing the gas to come out of the reservoir bag. When the patient exhales, what's going to happen is it closes that flap, and now the gas has to go out the side ports. Some of the newer ones have one valve. Some of them have two. Well, you're not going to see that many. And then some of these really don't have any at this particular point in time, okay? Part of the reason is that patients have become disconnected from their flow meters, and because of the high buildup of the CO2, they have actually died as a result of it. Same requirement, bag has to remain 1/2 2/3 full at end inspiration. And they're telling you the flow still has to be a minimum of 10 liters per minute. Normally we run at about 15 liters. We can bring it down from there just a little bit, but somewhere between 10 to 15 is what you're looking for. FiO2 somewhere up to 60 to 80%. We still call these 100%, but they're not 100% because of these valves on the mask. Also, the fit of the mask. If your mask isn't sitting very tightly on your patient's face, they're entraining outside air, and if they're entraining outside air, they're diluting that so-called 100%, okay? So just remember with these, the major difference between a partial and non-rebreather is this little bitty one-way valve right here. Now, a troubleshooting point is this. If you're looking and, the patient looks good, but not quite where you think they should be with this non-rebreather, go ahead and look at that little valve. If that valve is not moving, then there's a possibility it's stuck. Take your gloved hand. You can just move it up just a little bit, see if it'll loosen it up. And if it does and starts moving, and like I said, not much, just a very, very small amount, then you know that was stuck at that particular point in time. Now, when you talk about the book, one of the things the book is going to say is that I can add humidity to these devices. We've actually had these in the lab where we put humidity on them, and it's really interesting to watch the water come down this small bore tubing, come in here, and then drop into the bag. So I'm not quite sure I want to use humidity on this. And that's basically your low flow devices. There is a transtracheal, no, not transtracheal, there's also a nasal catheter. And it's a catheter that goes through your nose and down into your airway a little bit. And we don't see that very often because people don't tolerate it very well. Okay. So high flow devices, if you remember, have to meet and exceed the patient's inspiratory flow / demands, okay? And how can we figure this out? Well, if we know what the patient's minute ventilation is, and remember that's your respiratory rate times tidal volume, we can multiply it by 3 or by 4, and that gives me the patient's inspiratory demands. Now, what the 3 and 4 represents is a 1 to 2 IDE ratio, that's your 3, or 1 to 4 IDE ratio. Or 1 to 3 IDE ratio, that's your 4 at this particular point in time, okay? It provides a stable FiO2. It's really crazy when you're looking at the books and you may be looking at some other things they're going to tell you. High flow devices, stable FiO2, except if they're a low flow, they're not. But we still use them as high flow, and you're like, okay, whatever. Just go with it, okay? That they do meet the patient's inspiratory demands and needs, and we do give them a fairly stable or fixed FiO2. RAF does not affect these devices at all. There is a formula, it's called the O2 to air entrainment formula, or the air to O2 entrainment formula, however you want to put it. Most of these use ports and jets, Fisher sharing and vortices. These are your Venturi mask, which is also the air entrainment mask. These are your large volume nebulizers. So just to show you the formula here, There is a magic box that looks like a game of tic-tac-toe, and I used to sit there and go, can I play tic-tac-toe? Because I don't understand a clue what you're talking about. So then they came out and said, hey, there's really a formula. And I'm like, oh, bless you. Thank you so much. And the formula is basically 100 minus the FiO2 divided by the FiO2 minus 21. So because these are high flow devices, when the physician is ordering this, they're going to tell you, I want this at 35%. I want this at 60%. I want my patient to get 40%. That's what I want. There's my FiO2. So I know exactly what my FiO2 has to be, okay? When I go ahead and do my division, I'm going to come up with X over Y, okay? X is your air, Y is your oxygen. And Y is on the bottom here, it's the denominator, and it's always 1. And folks go, why is it always 1? And I go, that's really a good question. Maybe you guys can tell me because I'm not sure what the answer is. The answer is really, really very simple. You're using an oxygen flow meter. And so one part of whatever you're delivering to that patient is 1, okay? And then we'll build on top of it. So once I have my X and my Y, what I'm going to do is add them together. When you look in the book, they're going to do X first and then they add Y to it. Much, much easier to remember just to add the two together. And then to find out the flow that the patient's receiving, take your X plus Y, find out what your flow meter setting is, multiply the X plus Y times the flow meter setting. That gives you the total flow the patient is receiving, okay? And do you know if the patient's comfortable? Are they getting enough flow, not getting enough flow? Best way, best thing to do, always ask them. Do you feel comfortable? Do you feel like you're getting enough air? If not, titrate up. If it's too much, titrate down. So here's an example for you. We have a patient on a 35% Venturi mask, and we know the flow meter is going to be set at 10 liters per minute. At least that's what we think we're going to do. So we need to know what total flow is this patient going to be receiving. So we're going to do our formula, 100 minus 35 over 35 minus 21. We do use 21 for this. And that gives me 65 over 14. Now I got to give the bottom part to 1 because that's my oxygen. The 65 represents the air, the 14 represents oxygen. So it's 4.6 to 1, okay? 4.6 is the liters of air that I am in training for every 1 liter of oxygen set on the flow meter, okay? So if I didn't set the flow meter any higher than 1 liter, then the total flow the patient would be getting would be the 5.6. 4.6 plus 1, that would be the only flow that that patient is in fact receiving. So there you see it. Every liter set on the flow meter, patient received 4.6 liters of air and 1 liter of oxygen. And there you can add it together, okay? So the flow meter is set at 10 liters, okay, yay. So if I go 4.6 plus 1, there's my 5.6, but I've got 10 liters on that flow meter. 10 times 5.6 is 56 liters per minute. That's the total flow going to the patient, okay? And the patient may tell you, man, that feels really, really good. Just leave it alone. Okay, you're good. Or they may tell you, I think my eyes are falling out of my socket. Can you turn it down? Go ahead and turn it down a little bit or titrate it down for that patient. So just to show you, this is more of the long way, just in case people have questions. It's not a problem. As you can see, the air is always going to stay at 4.6. The oxygen is always going to be 1 part. So if you only have 1 liter, the total flow is only 5.6. But if you every time you add a liter on the flow meter, you're adding another 5.6 to it. And if you come down, because I have 10 liters on my flow meter, and come all the way down here, and you add 5.6, 5.6, 5.6, 5.6, da 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 da, you're going to still come up with that 56 liters per minute. So guess what? Sometimes we know what the total flow the patient needs, but we don't know how to set up for the flow meter. So there's really two ways to determine this. And the first one is if I don't really know what the patient needs, I have to, since this is a high flow device, I have to be able to deliver at least a minimum of 60 liters per minute to that patient, okay? So if you ever see a problem and the problem says, I have this patient, they're on this device here, where do I set the flow meter to deliver whatever, and they don't give you something to deliver 60 liters as the default. Or if I know what the patient's minute ventilation is, I can go back to that slide 12, and multiply the flow that I think this patient has, or the minute ventilation, by 3 or by 4. Okay, as you can see, 15 times 3 is 45, 15 times 4 is 60, so I'm still at my 60 liters per minute. So what are we going to do? Well, the nice thing about this formula is that the ratio is the ratio is the ratio is the ratio. And the ratios aren't going to change. They're going to be the same no matter what you're doing, okay? So using that 35%, you know the ratio is 4.6 to 1. We're going to add them together. There's your 5.6. The required flow is 60 liters per minute. That's what I have to deliver to this patient, okay? And so I'm going to divide that 60 by that 5.6, and I'm going to come up with approximately 10.7 liters per minute. Now, I'm not going to set 10.7 on the flow meter. I'm going to set a flow meter of 11 liters per minute. And you can say, well, that's going up. That's perfect, because some patients want more than what we're delivering. If they're not happy, those patients will tell you they're not happy. And so be prepared just to either titrate up or titrate down. Now, sometimes with the higher flows, we're going to find out that we have a problem. Venturis, for the most part, shouldn't be much of a problem. There's some new ones on the market that go from 24 to 55%. That's not a big deal. We can handle that. The majority that you may see are going to only go from 24 to 50% for oxygen. But now we have a patient who's on a large volume nebulizer, and he's getting 60% FiO2, and he needs 60 liters per minute of total flow. What am I going to do? You know, this is going to be a long day. So I got to get my ratio. 100 minus 60 over 60 minus 21 comes to about 1.03 to 1. On your board, you can use a 1-to-1 ratio. Isn't that nice? Okay. So 1.03 plus 1 equals 2.03. I now know what the ratio is. For every liter of oxygen on my flow meter, I'm going to entrain 1.03 liters of air. So I got to deliver 60. Well, 60 divided by 2.03 is right around 29.6 or 30 liters per minute, okay? If you remember looking at the flow meters, there was some, I think, air one that was kind of high, but the majority of them go up to 15 liters. Okay, so what am I going to do? Okay, set up two devices, make the patient more uncomfortable? Probably not. What I can do is say, okay, I'm going to use what we call a tandem setup. A tandem setup is where I'm going to go ahead and remember that double striker we showed you had the two areas where you could hook flow meters to them. I'm going to get one of those, put it in my dis outlet, and now I have my two dis outlets for my flow meters. And what I'm going to do is take two large volume nebulizers, because this has to be a large volume nebulizer. I'm going to set both of the large volume nebulizers on 60% oxygen, and then I'm going to turn them up, each of them up to 15 liters per minute. 15 plus 15 is 30. My patient is now getting their 30 liters per minute. Okay. And because it's 30 liters per minute for each of them, multiply that by 2, the patient's now getting their 61 liters per minute. Okay. They're getting 30 from each of the flow meters. Together, both of those flow meters are putting out 61 liters per minute. Howsomever, Some patients have higher FiO2s. This one has 70%, okay? Ratio for 70% is 30 to 40 over 49, which means that we're only entraining 0.6 liters of air for every 1 liter of oxygen. This is interesting. Inspiratory flow, still got to meet that 60 liters per minute. So there's my ratio. Let's add it together. 0.6 plus 1 is 1.6. 60 divided by 1.6, 38 liters per minute. Okay, let's see. 1 flow meter is 15. 2 is 30. Now I'm 8 liters short. Okay. You cannot set up a triplet, okay? If you do, the flow is running into each other, and when it does, you lose flow, and the patient was nowhere near that 60 liters. And so what we have to do at that point is we're either going to use a blender, or we have to get another device that can deliver the 70% to them, and that's what we'll set them up on. Okay, so we looked at the Venturi mask at the lab that one time. There we go. And the one that you guys had, that little green one, remember you have both the white and the green portions down here. And there's the little barrel that's for your mixing. Look at the ports on the side here. If you notice, there's no little ones in here. It's all one great big open one. And it too has that adjustable nose clip. This is also called, not only that Venturi mask is called a Venturi mask, it's also called an air entrainment mask, okay? The mask takes on the name of the device it's hooked up to, and that's where the air entrainment comes into it. So with these, the flows with the Venturi mask anywhere from 3 to 15 liters per minute. Manufacturers will tell you if you set this up this way and use this flow, and you guys saw that on the little devices, this is the FiO2 and the flow you should be getting. Sometimes they're a little off, so always do your math, okay? It's a fixed FiO2. We don't normally humidify these. Part of the same reason, you've got small bore tubing. And so if you have it running about 15 liters, you're going to see some water flowing down that tubing. And when that water flows down that tubing, in this case, it's not going to make it up through here, and it's going to start backing up. And now you have an obstruction down here. Again, it's a mask. A lot of people do not like masks. They're very confining, claustrophobic, hot, make you sweaty, and you can't eat with it. Although you could smush the food up a little bit here and just push it through the hole. It's much bigger. Anyways, doesn't work too well. And in this one, remember, these actually use jets. With our nebulizers, that's more of an older nebulizer, but it's still the same thing. It's a large volume nebulizer. There's your disconnector up here. The variable air entrainment report, remember, this ring had like 28, 30, 35, all of the FiO2 set on it. You have a jet orifice in here at this point, and you have a capillary tube that goes down here, a little filter, and it's going to go ahead and take care of that water, break it up for you because it works much better. These deliver a stable FiO2. They also deliver an aerosol. And so when someone is on a high flow device, it's very, very drying. At least they're going to get some moisture with this at this particular point. This can be heated. This one is a little bit different than the ones I showed you when you were in the lab. If you remember, had that long little narrow neck on it. This is, the heater fits over this. It just slides right over it. It's called a donut heater. And we looked at the donut heater, can't believe how sophisticated it is. It has an on and off button, and that's it. So anyways, the flows are anywhere from 3 to 15 liters per minute. They do have to give you an output of 60%. FiO2 is anywhere from 28 to 100%. Now, one of the questions that gets asked on the boards, and sometimes by your instructor, if you set a patient up, you have a patient who comes in, you need to set them up on oxygen, and you need to deliver a lot of oxygen to them. So what do you want to do? Well, the two of the answers are really like, yeah, no way. One of the answers is going to say, how about an aerosol mask attached to a large volume nebulizer at 100%? And another one will say, well, why don't we just use a non-rebreather set at 15 liters? Most people like to go and pick the aerosol mask with the FiO2 of 100%. The answer is the non-rebreather. And the reason that you say that is if you use the formula, 100 minus 100 is 0 over 100 minus 21, and you come up with 0 over 79, okay? 0 means you're not entraining any outside air. The only thing you're delivering to that patient is what's coming out of the flow meter. If the flow meter is set at 15 liters, the max amount of delivery that you have for that patient is going to be 15 liters. So the answer is the patient needs to have the non-rebreather. That's the only way you can assure that they're going to get the FiO2 that they need. With 100%, they're not, because they have to entrain outside air, and that really dilutes what you have at that particular point. And there's your aerosol mask. There we go. And you can see there's the holes on the side of it. This is called a face tent, okay? Some people go, well, that's a tent. Well, not literally, there is a tent, but that's not it. There's a pediatric tent, an adult tent. Haven't used them for quite a while. What they sometimes look like, if you've seen those great big boats that are down in the Everglades, and they have that thing at the back of them, and it spins, well, you have to set up the arms of the tent, and it sort of looks like that too. Someone once said when we were talking about this, is that we probably haven't set up a tent for at least 20 years here in Tucson. They may set them up other places, but we're not. So these may require the tandem setup. They can cause bronchospasm, fluid overload, overhydration of secretions, contamination, because they're connected to water. And anytime you start talking about water, you got to be concerned about that, okay? We also have a trach mask. It's not on here, but it's a mask that actually fits over the patient's trach and has the same cautions and everything that we see with the aerosol mask. The face tent, sometimes you'll see this on the patient who's had some type of facial surgery, reconstructive surgery, sinus surgery on occasions. Same thing. The flow is 3 to 15 liters, FiO2 28 to 100%. If these guys are laying down, it's like having the babes in the hood. The oxygen is going to go ahead and settle out at that particular point. Then the high flow nasal cannula, when it made its way into Tucson, it was actually being used at the peds, not with adults. Vapotherm was the first one that came out with it. They're still in business. Whenever you have a high flow nasal cannula, it has to be humidified, and most of these nasal cannulas have their own humidification systems, okay? FiO2 range anywhere from 35 to 90%. Flow sometimes up to 40 liters. There's one that actually goes to 60 liters per minute. Variable or fixed FiO2 just depends on the system that you're talking about. Teleflex is another one. It's called Comfort Flow. It also has heated humidity, goes from neonate to adult, and it uses a conchotherm, and we'll talk about that when we get into therapeutics too. And all of these have their own special nasal cannulas, and this one goes up to 40 liters per minute. This is Fisher and Paykel, okay? Mr. Paykel is actually from New Zealand. That's how you pronounce his last name. And they have the OptiFlow. This one goes up to 60 liters, and it's delivering that humidity through your nostrils, okay? And just a little bit with it, you have continuous high flow oxygen, washes out the upper airway. The reservoir of oxygen in the upper airway is available for gas exchange, avoids rebreathing of CO2, so it's supposed to also not blow off the CO2. One of the articles I was looking at said that people say you also have PEEP. Remember, PEEP helps to hold your airways open, but this particular author doesn't believe that that's actually what's happening. And here's two pictures of them. Here's the Fisher-Paykel, and there's the Vapotherm. Okay, and that's how it could be set up. And this one is actually hooked up to a blender. Okay, remember your blender is your proportioning valve. Okay, requires 2 gas sources. Should be able to provide anywhere around 60 liters per minute. FiO2 is 21 to 100%, and it actually can meet the needs of the patient. And there's 2 blenders here on the picture here. If the other one comes up here. This is sort of what we saw when you were in lab. When you're using this to deliver oxygen from here to a patient, you have to use a flow meter, okay? You set the FiO2 on whatever, on here, on whatever FiO2 that you want. Then we hook up a large volume nebulizer here, and we keep that on 100% oxygen. The reason we do that is that if I'm delivering 40% oxygen out of here and I set my large volume nebulizer at 40%, I'm now blending 40% with whatever's coming from the outside, and my patient's no longer getting 40%. So they're going to get 40 out of here, goes through that large volume nebulizer that's set at 100%, and the patient, in fact, is getting 40%. And then we're going to talk about CPAP BiPAP, and that'll be part of the lab on November 10th and 12th at this particular point. This is one of the newer machines, nice push button, finger controls, all that good stuff. So we'll talk a little bit about those. It is a high flow system. It can help to prevent intubation. The high flow nasal cannulas also help prevent intubations. They're sort of giving the CPAP BiPAP devices a run for their money right now. It does help reduce CO2 and respiratory failure. And we can do it through a mask or an ET tube or nasal pillows. We can set the flow to meet the patient's need, and again, the oxygen anywhere from 21 to 100%. And this is a home unit. This is a home CPAP unit. And you can see it's got a single circuit at that point. And this one is the headgear that's put on it. You guys will have a chance to see those. Just talks a little bit about how it works. Nice to take a look at it. So there's troubleshooting for both of these, low flow devices, inaccurate flows. If the flow meter is supposed to be at 5 liters and set at 3, it's an inaccurate flow, okay? System leaks. Nasal cannulas, for the most part, as long as you have them in your nose and you can breathe through your nose, you should not have a system leak. However, if it's sitting on top of your head because it bothers you while you're eating, you have a system leak, okay? There are obstructions. Where do we get the obstructions for some of these devices? Remember I talked about water in the tubing. We see those. Also, people have a tendency of coming in and standing on the tubes. They either put the chair leg on it, or they compress it between the mattress and the bed rails, or they just come in and the tube is laying on the floor and they just stand on it. And the person's going, I'm not getting any air. Oh my gosh, we have to call the nurse. We need to call the nurse. Okay, just move your feet. You'll be okay. These devices, for the most part, especially with the nasal cannulas and everything, do not stay put. They have a tendency to slide around. So sometimes in the morning when we would go see these patients, their nasal cannulas would actually be in their ears or they'd be in their eyes, and they'd tell us, oh, my eyesight's so much better. I don't feel too well, but my eyes are much better. And then skin irritation. Like I said, sometimes they pull on the ears and they do things like that really bother folks. The reservoir systems, patients do not like masks. They're hot, they're claustrophobic. Unless they're pretty out of it and they really need them, then we can use those masks. Lack of flow, if that flow meter gets turned off or disconnected, we have a problem. When we try to put humidifiers on some of these, they start to pop off. the bag collapsing because we don't give them enough flow. And then pressure discomfort is also another one that we see with them. High flow, we need to make sure we're delivering that correct FiO2. Have we set it up the way we're supposed to, okay? Just because, you know, in one set, the 50% is orange, the next one that you get, the 50%. So anyways, you know, the next one may not be the same color. It could be green. Downstream obstructions. Remember we talked about that in lab and saw that when you put water in the system or you put mucus in the system, it's going to decrease that entrained air and increase the FiO2. Remember with the Venturi mask, if you cover up those little ports or windows that allow the outside air to be entrained, you're going to give your patient 100% oxygen. So you do have to watch that too. So this is one of your attendance assignment slides. This is slide 32. This is slide 33. It's also part of that attendance assignment. And then this is slide 34, where you get to practice your high flow, okay? And what you're looking for at this point is how much total flow is being delivered to your patient. So remember, you're going to have to figure out the ratio and then multiply that ratio after adding it together times the flow meter. If you have a problem with these, please let me know. I am going to post a worksheet for you to be able to practice these, but this is your introduction to it, so it should work out fairly well for you.